they showed that 39%, if I remember correctly, 39% of women who froze their eggs using the conventional way had babies. Another study from another clinic, I can't remember which state, 32%, 32, which is a third. So that's really low if you think about it. Very, very low. And I can tell you, with all my respect to any doctor, the more you pump patients with shots, the worse the egg quality. It's studied, it's a fact. Studied one of the best study in endocrinology, which is basic science. They study cellular mechanism of how these high doses of shots can hurt the egg quality, and I see it every day. So people get excited about the quantity. I don't. And if you think you have 20 eggs and you're going to have baby, I hope to God you would. But only 1 out of 3 women like you will have eggs. And to me, that's scary. That's scary. So that's why I believe in low dose egg freezing, or LDE, which is really, I'd rather have less eggs with better quality than not.
In today's interview, I had the pleasure of interviewing Dr. Merhi. Dr. Merhi is the founder and the medical director of Rejuvenating Fertility Center. He is an internationally recognized fertility doctor, lecturer, editor, and grant reviewer. His training and faculty appointments included Albert Einstein College of Medicine, Montefiore Medical Center, NYU School of Medicine, and University of Vermont. Dr. Merhi was a professor at SUNY Downstate Health Sciences University and the director of the Reproductive Endocrinology and Infertility Fellowship Program. Dr. Merhi has 3 American board certifications in OB-GYN, reproductive endocrinology and infertility, and high complexity laboratory director. Dr. Merhi is one of few reproductive immunologists in the country and is an active researcher with an interest in women older than 40 with low ovarian reserve, low AMH or high FSH, stem cell ovarian rejuvenation, gentle stimulation IVF, natural IVF, and IVF without injectables. He was named one of the top 2% scientists in the world. In our interview today, I spoke with Dr. Merhi about PRP and natural IVF cycles. We discussed ovarian rejuvenation and what kind of outcomes women who pursue PRP or ovarian rejuvenation might expect when it comes to fertility. We also discussed important considerations for women with endometriosis going through IVF and or fertility treatments. Before we jump in today, please give this video a like, share it with a friend, and hit that subscribe button if you haven't already. Now on to the interview. I am joined today by an amazing resource for fertility and PRP and endometriosis, all these things that we're going to talk about today, Dr. Merhi. So before we jump in, could you give us a little intro of who you are, what do you do, and what makes you a great person to talk to on fertility and endometriosis?
Well, first of all, thank you so much for having me. It's really an honor to finally meet you. I follow you on Instagram, and you're a great person and great resource as well. My name is Dr. Merhi. Excuse me. I'm one of the co-founders of Rejuvenating Fertility Center. With our mission is to help any woman, regardless of her age or weight, to have babies using her own eggs. We're not against donor eggs, but our vision is to move the field forward and change the fertility world. I think as far as great person, I don't think I'm a great person. I'm a good person, but as far as medical field wise, because I think I still have a lot of work to do for myself, and for the field, because I do think that there is so much out there that we really haven't translated from bench to humans. And that's why we opened RFC Bahamas, where we're doing things, even though not FDA approved, still, but have been shown to work and safe. And we're helping a lot of people with stem cells right now in the Bahamas. So as far as endometriosis, it's in our DNA as a fertility doctor, because I can tell you, even though endometriosis is percentage-wise in the world, where 3 to 7% of women, they say, or something like that, depending on the book. But among the fertility community, 50 to 60%, according to the ASRM, of women have endometriosis. If you go in and do laparoscopy on every single patient in a fertility clinic, you will find endometriosis. The question is, shall we remove or not? That's case by case basis. But all I can tell you, for me, I assume every patient have endometriosis until proven otherwise. It's always in the back of my mind. That's why I believe less medicine is better, because the shots and the heavy doses actually can flare up endometriosis and hurt egg quality. And no, it's not controversial. There's plenty of studies with respect to a lot of people who disagree. Second is, endometriosis is not just in the belly, it's inflammation all over your body. You live with it. So things you can work on lowering inflammation by diet, by supplements, by life changes. All those things can lower body inflammation, lower endometriosis, in my opinion. And we've seen it, we've handled it, we've studied endometriosis, we looked at study at ozone sauna and endometriosis. We monitor inflammation in the blood for those patients after ozone sessions, 3 weeks. We monitored also their symptoms, and everything improved. Ozone being a very powerful anti-inflammatory agent. So holistic, natural things can improve. And that's what I think makes me a good person to speak about endometriosis.
I love that. I love that you bring that in. It's unfortunate that still in this day and age, endometriosis patients are being told that diet has nothing to do with endometriosis, that you can't mitigate inflammation with endometriosis. Like, that's just wild to me. But that was a really great introduction, and you were alluding to a couple of these studies, and you recently actually posted about a study that I took a note about because I found it so fascinating. You said over 6 out of 10 women who froze their eggs were not able to even make one embryo because they were stimulated at high doses. So can you talk a little bit more about that? Like, what is the connection we're seeing between these high dose protocols and then like effects on egg quality or flaring endometriosis?
Look, I can tell you, I'm going to give you an example, okay, and then I'm going to expand to you the studies. I've had patients coming from other clinics, and I love all other clinics, but I'm not trying to, I'm a guy who believes that every doctor is amazing and they want to do the best for the doctor. So I would never badmouth any colleague ever. But I have patients coming from other clinics. Over 100 eggs retrieved from their system, or they had 40 eggs frozen, and when they thought, they did not even make an embryo, or they made an embryo and was genetically abnormal. I have patients, I'm not bragging, but I'm just giving you examples, who had 3 eggs frozen, have 2 embryos genetically normal, pregnant with baby, and still have a frozen embryo that's waiting for them in the freezer. Let me tell you how the reason why, and there's a study, if I recall, I know the study very well, from NYU, that one of the best centers in the world who started egg freezing, and they showed that 39%, if I remember correctly, 39% of women who froze their eggs using the conventional way had babies. Another study from another clinic, I can't remember which state, 32%, 32, which is a third. So that's really low if you think about it. Very, very low. And I can tell you, with all my respect to any doctor, the more you pump patients with shots, the worse the egg quality. It's studied, it's a fact, studied, one of the best study in endocrinology, which is basic science. They study cellular mechanism of how these high doses of shots can hurt the egg quality, and I see it every day. So people get excited about the quantity. I don't. And if you think you have 20 eggs and you're going to have baby, I hope to God you would. But only 1 out of 3 women like you will have eggs. And to me, that's scary. That's scary. So that's why I believe in low dose egg freezing, or LDE, which is really, I'd rather have less eggs with better quality than not.
Yeah. And that's achieved through lower doses, right? So you're not getting as much stimulation happening because they're lower dose protocols.
Yes, but Cindy, it's people think lower dose get less X. Actually, that's not true.
Oh, okay, great. That's good to
That's
know.
not true. It's a spectrum. The more someone have follicles, the more you need to give them medication.
Hmm.
Let's say follicles are like follicle where the egg is.
Mm-hmm.
Every month you have certain number of follicles to spend. This
Mm-hmm.
is your spending for that month. Let's say you have 10 follicles and your sister has 5 follicles. Okay, fair?
Mm-hmm.
The medication is food for those follicles. You have 10 I need to feed. I'm going to give you double the dose of your sister
Mm-hmm.
because she only have 5. Give them what they need to grow. Don't overfeed them. If I give your sister the same dose as you, I'm giving her medication for 10 follicles but only 5, and I'm forcing every follicle to eat double what she needs, and she's going to vomit.
Yeah, that makes sense.
So you're not going to get, if I give your sister the same dose as you, she's not going to get more than 5. The maximum she will get is 5 eggs. The maximum you will get is 10 eggs. Just give them what they need to grow without overfeeding them. That's the concept. So low dose really is individualized. People ask me on social media, is this low dose? I don't know, depending on everybody's follicle, number of follicles, age, weight, FSA, all those things determine what is appropriate dose. I always give this example of diabetes. I don't know if you know about diabetes. When the sugars go up, the higher the sugar in the blood, when you do finger stick, the more insulin you give yourself to lower it. Same thing, right? If you have a lot of eggs, give a lot of medication. Less eggs, less medication to get what you want. So it's a sliding scale.
That makes sense. So I guess my follow-up question then is, let's say before you've done any assessment on a person, you've not done an ultrasound, right? So you don't know how many follicles are growing. Are there certain things that can help you determine if somebody is going to be better suited to low dose or somebody's going to need higher dose, or do you need to do the follicle scan to determine how to tailor that protocol?
Well, that's a great question. You cannot guess without an ultrasound. But if I am in a desert and I don't have an ultrasound machine, age is what tells me how much I need to give. Women 38 or 40 and above, even if they have a lot of eggs, I'm gonna give them less what they need because their eggs become more sensitive and more fragile. Think about it, Cindy. When you and I were children, we would fall on the floor, we'll bounce back. Now, if I fall on the floor, you need to call 911 to pick me up. I give this example just to tell you that the body, the cells, as we get older, become more fragile. I could break a hip if I'm 70 years old, right? So the eggs become more sensitive, similar to the bone, to everything. The more you get, they cannot tolerate the high dose. So even if you have 20 follicles and you're 41 or 42 or 47, I'm giving you less, much less than, I don't want to feed all of them because that is going to actually hurt them too.
That makes a lot of sense. I love the analogies, they're super helpful. Can you compensate for that at all? You know, we know that there's a lot that helps with mitochondrial support, CoQ10 and high protein diets and exercise and these types of things. So let's say you are even a little bit older, you're producing a lot of these follicles. We know that the follicles are a little bit more sensitive to these to stimulation. Can you compensate? Like if somebody is a little bit older, but they're, you know, really healthy, they're eating high protein, hot cold therapy, CoQ10, all these other mitochondrial support supplements, does that help?
Absolutely, and let me tell you why. And that, no offense, people who says you cannot improve egg quality, I think they're delusional. The egg of a woman is like the egg that we eat. There is the yolk, where there's the DNA, and there is the white, which is the energy. And I always describe it as the knife that cuts the yolk in half. Why half? Because I just need half of you and half of the partner to put them together. So the sperm has to split in half, the egg has to split in half, put them together. The problem is when women get older or they have issues, inflammation, endometriosis, PC, whatever you call it, the white, which is the knife, becomes tired and it's not sharp. It's not cutting the yolk in equal pieces. So if there's a bigger piece than the smaller piece, now you put adding the sperm, it's more than you need. To talk about numbers, you're 46 chromosome, your male partner is 46 chromosome, I need 23 and 23. If your egg splitting to 22, 24 instead of 23, 23, 24 plus 23 sperm, that's 47. We call it trisomy or extra chromosome. 22 and 23, 45, that's missing chromosome. It's not 46. So you're producing, but the white is what determined the division of the yolk. And you have the division happens around cycle day 8 of your cycle. So let's say a woman have 28 cycle. You ovulate on day 14. The follicle is now, with the period is small, it's still 46 chromosome. There's no splitting. The white hasn't acted. Once the follicle grows, the egg, the white starts to squeeze on the yolk to cut it. So it's around 12 millimeter, which is around day cycle 8 of the cycle. If you improve the white, sharpen that knife, and improve the mitochondria, you're more likely to split equally. Things that improves the white and the health of the white: diet, CoQ10, vitamin D, NMN, PRP for the ovaries. That's how they work. They don't work at the DNA is DNA. You don't change someone's stimulation. Let me tell you why high dose of stimulation causes abnormal embryos. And when I tell this to some patients, they look at me like, are you crazy? You have two heads. Let me tell you, remember we talked about the division? It happens between day 1 of the cycle and day 8. Fair? Now, when you give high doses, Cindy, you're pushing those follicles to grow fast to 12 millimeter. You're rushing. When you rush somebody to cut something, they're more likely to do mistakes and not split equally. And the white doesn't like to be rushed. That's why low dose produces more likely genetically normal embryos. Vitamins, all that stuff. So yes, the health of the white can be improved, and you can give healthy babies for women above 40 or older, or where they have endometriosis or whatever, through the diet and all these things.
Love that. That's really comforting to hear. That's excellent to hear. What about somebody who comes to you, they have a formal diagnosis of endometriosis. They know it's like stage 3 or 4. Do you have certain things in your protocols that you almost always will apply to women with endometriosis?
The answer is yes. Every person with endometriosis is different. There are people who have endometriosis in the ovaries, cyst endometriomas, right? But all I can tell you is I need to give lower dose of medication. Remember, we talked about the white and the egg. The white's already inflamed, and the medication increases inflammation. So you really don't want to push them hard. Less is better for those patients. 2, you don't want to increase their estrogen high. When you stimulate them and the estrogen become very high, estrogen is the enemy for endometriosis. A flare-up endometriosis causes pain and poorer egg quality. To lower the estradiol, I usually use a medication called letrozole. So lower dose of medication, an addition of letrozole medication. Those are, to me, the main things for women with endometriosis to yield a better quality egg.
Yeah, great. That's really, really great to hear. I like that. Letrozole is a good option, I think, for women with endo for sure. You had alluded a little bit to PRP, which is something that really caught my attention on your socials because you talk quite a bit about PRP and natural IVF cycles. Tell us a little bit about PRP. What is it? Who's a good candidate for it? And you've kind of already alluded a little bit towards what some of the outcomes are. So it really helps with that white of the egg and helps with the mitochondrial function and the quality. But yeah, who's a good candidate for it? What is it?
So PRP stands for platelet-rich plasma. I'm not that smart. I started in Greece 10 years ago, where they showed that when they did it for postmenopausal women, those women were ovulating and making healthy babies. Now, they took blood from patient's arm, spin it multiple times. You get the platelet-rich plasma from their own blood. Then they went vaginally Similar to egg retrieval, instead of sucking eggs, now you're pushing the PRP inside the ovaries. So now the eggs are living, the PRP is living there. It usually lasts for 3 months, they stay in the. Now, it does two things. It could improve quantity and quality. It could wake up more dormant eggs that women have. And yes, postmenopausal women have 1,000 eggs left inside their ovaries. And yes, you can still get pregnant even if you're in menopause. And yes, the Greek people have published this since 10 years ago. It wakes up those dormant eggs. And two, it improves the white we were talking about. It strengthens the mitochondria. It's similar to human growth hormone. HGH, a lot of people called Omnitrop, they give it for 2 weeks before you start IVF, have been shown to improve egg quality by improving the white. PRP is the same. It's the patient's growth hormone, growth factors, but you're putting them at much higher concentration directly inside these ovaries. And it will improve the division and it will improve the genetics. Why? Because now the white is sharper and it's going to cut the yolk equally to 23-23. We've published Dr. Seren Sechkin, who now works at, she was my fellow, she works at Generation Next. She's great, very smart. We did a study and she came to me and said, Dr. Merhi, I'm seeing all these people with PRP having genetically normal embryo. I said, why don't you make it your research? So we went back and reviewed, and she showed 5-time improvement in the genetics of the embryo. We published a study after PRP in the same women, before and after. So it works through improving quantity, quality, and the genetics of the embryo. Does it work for everybody? No. Now we do other things. I do adipose PRP now, which is I do mini liposuction from the belly, remove stem cells, mix it with PRP, and then inject them. We call it adipose PRP. Why? Because the fat have stem cells. And those stem cells, believe it or not, they can become any type of cells you want based on where you put them. If I take stem cells from your belly now, put them in your kidney, they have the potential to become kidney cells. That's regenerative medicine. Your body is treating your own. Why? Because they live in the kidney. If I take stem cells from your fat, put them in your liver, now they live in the liver, they become like them and they get activated. But they're younger than the liver cells you were born with, so they act better. Put them in the ovaries. They have the potential to become new, younger eggs, better than the eggs you were born with, because now they are transforming now. So that's called the adipose PRP, right? Which is a huge, but also those stem cells, they work through improving the whole environment of the ovary when you put them. It's like ovary is like a lake and the eggs are like fish. The water becomes murky and dirty as women get older and inflammation. The stem cells is cleaning up this dirt and mess for the water, for the fish to start to see and become happier and jumping, and you can catch them. So that's what stem cells do. They lower inflammation in the ovary. They lower the fibrosis, which is stiffness of the ovary. They lower the death of the cells. They do so many things for the environment, for where the eggs live. In addition to, they could become new, younger eggs. That's how it works.
Wow, that is fascinating. So two follow-up questions. So one, you had mentioned that it doesn't work for everybody. So I'm curious if there's sort of like a specific profile of person for which it doesn't work for. I imagine maybe like much, much older women would be my guess. And then this is injected into the ovary, you said, right? And so any concern
Correct.
over damaging the ovary with like repeated puncturing or anything like that?
Not really. You're actually people. Some people do 20 IVF cycles and they poked so many times. When you do regular IVF, conventional, and they get 60 eggs, the ovary has been poked 60 times. So the ovary is they're very forgiving tissue, right? And if you go and inject and puncture it, it will heal right away. When we do egg retrieval, the ovaries very rarely they bleed inside the belly. Why? Because they stop the bleeding. They're amazing. If I poke you right now on the skin multiple times, you're gonna bleed. But the ovaries, it oozes a little bit and then stops. Otherwise, people will die from bleeding inside the belly. Well, it happens rarely if you hit a vessel, whatever. But what I'm trying to say is the poking does not really affect the ovaries. The PRP and the adipose are the patient's own cells. We're not adding any chemicals to it. The FDA allowed us to do it, and they came to us, zero violations. We're blessed, lucky. But we worked hard for that. But what I'm trying to say, But also, if you want to wait for the FDA to approve things, good luck with that. Let's be honest here, right? They're just, it's a mess. But so that's what we do. Now we do things outside that the FDA hasn't allowed, which is umbilical cord stem cells. We do this in the Bahamas and exosomes, right? Those why? Because they're coming from newborn babies, and because you're taking them and putting them in your ovaries, this is when the FDA say, "Oh no, you can't. We don't. It's not officially proved yet." So that's why we do it in the Bahamas.
And then that other question about the kind of the profile of somebody who maybe isn't the best candidate for it. I don't know if you addressed that one.
Well, look, the reality is people, the candidate person, regardless of your age or weight, if you have low quantity or poor quality eggs, if you have failed IVF before, you are candidate. Even if you have a lot of eggs, if they're all bad, PRP and adipose PRP could help. So you're a candidate. If you're in menopause and you have no period and eggs are not coming out, you are a candidate because now you're stimulating the dormant eggs to wake up. So we do it for women in their 20s and women in their 50s. As long as the patient is healthy, it's okay to, you're a candidate. If you have medical issues and God forbid something could happen, then we're not doing anything. Even if you're 20 with, let's say, a bad diabetes and not controlled, we're not touching you. Even if you're 20, get healthy, fix that, and then come back. Because also we want to have a healthy baby. So,
Yeah,
yeah.
I hear you. I hear you. Okay, awesome. That's really, really interesting. And it sounds like there's some really cool new technology, getting more and more attention with like the stem cells and then the PRP, which is really cool. Is the ovarian rejuvenation that you talk about on your socials, is that the stem cells?
Yeah, so ovarian rejuvenation is a big term. It's an umbrella.
Okay.
And underneath it, there are PRP, adipose PRP, and umbilical cord stem cell and exosomes,
Okay.
right?
Yeah.
So you're basically, really the term is confusing and tricky. And let me tell you, and every time I give lecture to the university, I say, it's really, you can't return the clock. So that's rejuvenate. It's really, you really should call it intra-ovarian improvement of the tissue, or amelioration, something different than rejuvenation. It's really, I don't think it's the perfect word, but it's been used and people are using it. So we use it in the lay language term, but medically, it's really not rejuvenation.
Okay. Okay. Yeah, that answered my question. Okay, so because my population is mostly, endometriosis, whether the unique objectives of the individual are like pain management or fertility, what are your opinions on surgery pre IVF stimulation, post IVF stimulation? Do you have opinion about that? Do you have certain protocols or considerations when somebody has like a large endometrioma? I think you might have already kind of answered this question a little bit. We talked about like specific endo protocols, but I have talked to a few specialists, a few like endo surgeons, and everybody kind of has their own unique opinions on IVF pre-excision surgery, post-excision surgery. Do you feel like everybody with endo requires surgery? Like, what is your, with the caveat that there's a lot of nuance here, obviously, right?
Yes.
To be individualized.
Well, look, Cindy, every patient is different. Like I said, endometriosis can have cysts in the ovaries, endometriomas. If the endometriomas are small, leave them alone. Because if you go in and take them out, you're going to take the cyst and you're going to remove some normal tissue around it. Whether you like it or not, the ovarian reserve now is much lower, and you basically took away a lot of good eggs, right? If the endometrioma is big and you can't reach you can't reach the eggs because it's in the way, you have to take it out first. So there is no really right and wrong, right? But what I tell people is this: if you are in pain, the surgery is indicated to improve pain scale, right? If you, right, is it recommended to remove it for every single patient before IVF? The answer is no. The American Society for Reproductive Medicine did have guidelines from 10 years ago about endometriosis, and they said You don't need to take out before IVF because it doesn't really improve. People think endometriosis is just in the belly. It's not. It's in your whole system. You live with it.
Yeah.
It can come back in 2 weeks for some patients if
Yeah.
you take it out. Why? Sometimes it goes into the lungs, sometimes in the liver, but it's in your body, it's in your system, it's everywhere. So taking it out is not going to improve outcome because people take it out for implantation before embryo transfer. Well, if it's still in your blood and it's going to your lining, even if you take it out from your belly, it's not going to improve. And that's why the SRM said, well, listen, they have lower implantation, they have poorer egg quality, but they really did not recommend surgery because surgery also has serious consequences in certain patients. Sometimes you have to take out the whole ovary by mistake, not by mistake. If a patient is bleeding, you just want to save patient's life. That's why in the consent, there's a chance of removing your ovary. Sometimes you have to move tubes. Sometimes you had the bowel, sometimes the bladder. So I think every patient has to be individualized case by case basis. But for endometriosis, we know egg quality is lower because of the inflammation. Lowering this inflammation and improving egg quality for things that could be done for certain patients before you do egg retrieval is important. For embryo transfers, it's very important to understand that the lining is less sticky in those patients. There's a glue called integrin. It's less expressed in this lining. So you need to do things for it, right? That's why I'm not saying for everybody, I'm just saying people came up with embryo glue, with this, PRP, we do PRP infusion in the lining, we do PRP injection. Why? Because the platelets and plasma increases the glue. And that's why there are trials showing that if you do PRP for the lining of the uterus before implantation, a day or 2 or 3 before embryo transfer, it significantly increased pregnancy rates. And a lot of people nowadays, a lot of clinics, a lot of universities even, finally are using PRP for the uterus because the studies are really compelling and there are trials, right? So
Fascinating.
yeah.
Fascinating. What about suppression? What's your opinion on suppression of endometriosis patients with like Orilissa or Lupron?
Look, I mean, the reality is this, right? There are older studies showing that suppression could improve outcome. You could do that for 3 months with Lupron, put them in menopause, which I hate.
Side effects.
It's hard to be in menopause for 3 months with hot flashes, irritability, can't sleep, low libido, everything. I like more Orilissa before. I usually give it for 2 months or so before you do the embryo transfer. However, back to my point that I mentioned earlier, I assume everybody has endometriosis until proven otherwise. So, it's case by case basis, to be honest with you. Now, a lot of people want to do Receptiva. I don't know what this means.
Okay, yeah.
It's a marker.
Yeah.
It's an immune thing that people do in the lining. If it's positive, it might indicate you have endometriosis. But a lot of people have endometriosis and they have negative Receptiva.
Of course.
And vice versa. So I can't, I used to get positive Receptiva patients and send them to Dr. Vidali, who's one of the best surgeons, in my opinion, for endometriosis. Like, Zaher, stop sending them because I'm not doing surgery just because of Receptiva. He's right. You need to, again, it's case by case basis. It's symptoms, it's lining, it's thickness, it's history of implantation or not, history of recurrent miscarriages or not. Now we do immune issues, immunology as well. We do a test called the Pregmune, which tells you if you have certain level of inflammation, especially for endometriosis patients. Why? Pregmune, Pregmune. It's pregnant and immune. And that test, I like it. And this is why, we took over the reproductive immunology program from BRI, Braverman, when they shut down back in August. And we've helped a lot of people. We're actually presenting a data. Jessica Harun, our nurse and partner, she's presenting data in October at the ASRM. You test them and you target their immune system based on what you find in the Pregmune. Why? Inflammation is bad. And if you have certain types of inflammation, your body will attack your own embryos. Why? Because the embryo is foreign to your body. Yes, half of it comes from sperm, and sperm is foreign to your body. So if you have mismatch between you and your husband, called HLA type and stuff, then you really need, it's like doing kidney transplant for somebody. You need to find the perfect match. I'm not saying change your husband or partner, but there are medications to suppress your immune system in the lining of the uterus to allow this implantation to happen for the first trimester, then you let them go.
Yeah.
That's why we do reproductive immunology, and we're one of big ones in the East Coast. So it does work. There is so much that we still need, but all I can tell you is the body is not and you're not an egg and a uterus. Okay, you are a whole thing, right? Your immune system, your inflammation, your diet, all those things play a role in making a baby.
Yeah.
That's the reality.
100%. Yeah, I'm happy that you brought up the immune piece, because I was going to ask you that next. So do you dabble in like immune suppressants and IV immunoglobulins, intralipids? Like, do you dabble in those? And is that something that you find beneficial for a lot of endometriosis patients? Because I think the literature is quite clear on these immune issues. They do tend to be a little bit more common in endometriosis patients, right?
Look, the reality is this. Everything is inflammation in our body, whether we like it or not. I don't care what anybody disagrees. Everything is inflammation.
Yeah.
Everything. Aging is inflammation.
Yeah.
Arthritis is inflammation.
Yeah.
Alzheimer's inflammation. Everything is inflammation. So if you tell me inflammation doesn't play a role in implantation and miscarriages, you're delusional. That's one. Yeah. Two, the body, you need some type of immune system to protect yourself from infections, bacteria, all that stuff. If it's too much, then you're attacking your own embryos.
Yeah.
So it's a fine line. You need a balance between inflammation and anti-inflammation for a successful pregnancy to happen. The implantation process is all inflammation. So many immune systems change the whole uterus because of the implantation. Miscarriages, all those things. So, and we're seeing, Cindy, more and more of this because, excuse my language, we eat shitty food. We eat shitty plastic in every water. We have cell phones everywhere. We live in an environment that's very inflammatory. And whether you like it or not, why more and more people having infertility? 1 in 5 couple now. It used to be 1 in 12 couple. At the same age. It's not because people are waiting longer. No, I'm talking about same age group. Why premature ovarian insufficiency, POI, used to be called POF. I don't like the word failure because it was removed from the book. It used to be 1% of people in the world have it. Now 3.5%. Yeah. According to the ASRM and the ASHRI, 3.5%. So 350 times increase in women going into early menopause before the age of 40. How can you explain that to me? It's environmental.
Yeah, I agree. There has to be an explanation for it.
What is?
Yeah.
There's no other explanation.
Yeah. It's crazy. When we moved into our house, we did a test of our water and there was arsenic in our water. And I was like, what the heck?
But that's what I mean. Now there are studies on rice, the food, and then tampons, condoms, makeup. Every day there is something.
I know.
Those are the things. And it's getting worse. And I tell patients in 2 generations, most people will need infertility treatment. Getting pregnant naturally, you need to open champagne. If it happens naturally, you need to open champagne.
Yeah.
Because look, Cindy, what we see now is transgenerational. You pass it to your children.
Yeah. And
it becomes more magnified in the following generation.
Yeah.
So it's not just, okay, it's getting worse and worse with every generation.
Yeah, I agree. Yeah. It's often a thought that crosses my mind, like when I'm working with somebody with endo and they have all these autoimmune concerns and their pain is really severe and then their thyroid antibodies are through the roof. And the questions, enter my mind, like, how far back does this go? Is this something that your mom was exposed to? Were you exposed to it in utero? Like, how far back does it go? Because I think that when somebody's got a couple of these negative things compounding on top of each other, it's probably at least partially genetic, or it traces back to your parents and the health of your parents and how well they cared for themselves. So I definitely agree that it passes through the generations, right? For sure.
Well, listen, I mean, the reality is there is Barker's hypothesis, right? I'm not sure if you Barker. Barker. It's well known that the in utero environment can shape your future.
Yeah.
Shape if a woman gains, even if she's skinny, by the way, if she gains a lot of just during the pregnancy, the baby will be predisposed to diabetes later on in adulthood. If you have a obese patient who doesn't gain a lot of weight, her child is less likelihood to have diabetes. So that phase in utero is called Barker's hypothesis, shapes the whole system forever.
Yeah, I hear
Yep.
you. It's so interesting. Okay, so insightful, such an insightful conversation. I guess we're running out of time here. So I guess my last question to you, Dr. Merhi, is, for anybody watching who knows they have endometriosis, they've been trying to conceive, their next step is to explore, IVF or some other kind of assisted reproductive technology. I know that this is a big question, but any advice besides maybe coming to see you? Any advice there? Any red flags or any considerations that
I don't want more patients, please.
he's too popular,
No,
too in demand?
don't. I don't want. Look, the advice is this. You need to live with endometriosis if it's something that you're living with for the rest of your life. I hate to say that.
Yeah.
That's one. Two is you're not an egg or a uterus. Endometriosis is an inflammatory process. It's all over your body. Work on lowering the body inflammation as much as you can, whether with, of course, I don't like chemicals, vitamins, diet, all those, whatever you think could help. Work with a team, right? Because IVF is not always the answer. And you see a lot of people pump with shots, endometriosis, bad egg quality. They tell them you need donor egg. Well, you know what? You cook those eggs because she was already half cooked the egg. So try to work on that system because everything is interrelated with each other to produce that cute baby. That's my advice.
Love it. I think that's a fantastic way to end off our interview. Really appreciate your time. Very insightful, very
My pleasure.
Mind-boggling information that I think many people will benefit from. So thank you. Can't thank you enough.
My pleasure.
And
my pleasure. It's really a pleasure to talk to you, Cindy.
Thank you so much for watching today's video. If you haven't already, please hit that like button before you go, and we'll see you in the next video.